My name is Lacey Ruby, and I am a student nurse in the Whatcom Community College RN program. The topic discussed today is the importance of nurse-initiated sepsis protocols and why Peace Health hospitals should implement them. By the end of this presentation, you should be able to identify current criteria for sepsis, describe standard guidelines for treating sepsis, define nurse-initiated protocols and how they work, identify what current Peace Health policies are, describe how and why Peace Health policies should change. Sepsis begins as a systemic inflammatory response syndrome, or SIRS, that can lead to organ failure, shock, and death. The Center for Disease Control and Prevention reported a significant increase in sepsis in the United States and the high mortality rate of such a diagnosis. Early recognition and treatment of sepsis are necessary for the best outcome. Often, people do not seek medical help until the infection has reached severe sepsis or septic shock. Evidence suggests each hour without treatment increases the risk of death. Anyone can get sepsis, so in the hospital setting, the staff should always suspect sepsis. It can have a sudden onset and a quick decline. Those most at risk are patients who already have an infection. However, burns and other types of trauma are also frequent culprits. Even surgery can be a source of sepsis. Any opening of the body for surgery can invite infection, no matter how sterile the technique, or invite an immune response of inflammation. So what should a nurse be looking for in their patients? SIRS, or early sepsis, requires any two of the following: a temperature that is above 38 degrees Celsius, or a temperature that is below 36 degrees Celsius, a heart rate that is above 90 beats per minute, a respiration rate above 20, a white blood cell count over 12,000, or going towards neutropenic and under 4,000. A lactic acid above 2 is also a symptom of SIRS or early sepsis. This point is the best time to recognize and treat the patient before the infection becomes systemic and the patient has sepsis. An acute change in level of consciousness or cognition is a sign the infection is worsening. With a decrease in their baseline blood pressure or a decrease in urinary output, there should be concern over the severity of the sepsis, and a new onset organ failure begins the next stage. Quickly, shock and then death follow if left untreated. What standards and guidelines are evidence-based? Surviving Sepsis campaign is a collaboration of the European Society of Intensive Care Medicine and the Society of Critical Care Medicine, and along with the sponsorship of over 20 medical and healthcare organizations over the world, have created international guidelines for management of severe sepsis and septic shock. Included in these organizations are from the United States, such as the American College of Emergency Physicians or the American Association of Critical Care Nurses. Other nurse organizations include the World Federation of Critical Care Nurses. All evidence-based research of protocols for sepsis included in this literature review hold to the standards of the Surviving Sepsis campaign or base research on their guidelines. The current guidelines suggest that you should immediately obtain blood cultures before any antibiotics are started, and an empiric or broad-spectrum antimicrobial should be begun at this time. Within an hour, a specific antimicrobial should be started for this infection. Within 3 hours, the guidelines state you should have obtained a lactate level, and you should be administering 30 milliliters per kilogram of crystalloid for hypotension, or a lactate that is greater or equal to 4. The crystalloid should not be hydroxyl starch colloid, so it should not be lactated ringers or have bags with dextrose in them. Within 6 hours, vasopressors should be ordered if the fluid resuscitation has not brought the blood pressure back up to a baseline, and a blood draw of lactate level should be taken again, along with further reassessments. Surviving Sepsis campaign strongly recommends protocols and quantitative resuscitation and routine screening. Evidence-based research strongly recommends using electronic screening tools to look for specific clinical manifestations in vitals and labs, and routine screening in not only the emergency department and ICU, but also on inpatient floors. Evidence-based research strongly recommends protocols designed by a multidisciplinary team, including physicians and nurses and respiratory therapists, and protocols that can be nurse-initiated. Nurse-initiated protocols are a set of standing orders by a licensed medical care provider, most often a doctor, in which specific circumstances, defined in the order set, allows a nurse to begin the protocol without calling a doctor for more orders. The benefits for this are manifold, but amongst them is that you can immediately begin treatment for critical or rapidly occurring medical needs, such as sepsis. The orders are then consistent and standardized, and lab draws are completed without discrepancy or variance from differing doctors in a hospital setting. Because multiple doctors will be caring for a patient throughout the day and throughout the entire stay of the hospital, it is important to have standardized orders for diagnoses in a hospital. They can also be started without awaiting calls or orders from doctors who might be on call or busy elsewhere in the hospital at the time. During night shift, there are less doctors in the hospital, and it takes time in order to notify a doctor and have them call back with information, and that's time that is taken away from treating the client. The current practice at Peace Health involves many different orders for sepsis. The one on the screen is the standing order for the emergency department. There are no screening policies except for where it's mentioned here. There are no screening policies in place for the hospital-wide to screen specifically for sepsis. This standing order is the closest thing to a nurse-initiated protocol, and it is only available in the emergency department, not even in the ICU. There are no orders for empiric or broad-spectrum antibiotics on it. This is part of an order set for general adult sepsis focused. These are ordered for ICU, but they're ordered in addition to standard ICU orders. These only have as the standing orders on here is to notify the doctor to start a peripheral IV if necessary and what the treatment goals are. All other orders on here have to be specifically added by a doctor. So not only are these not standing orders, they're only for the ICU, and they have to be ordered in addition to normal orders on that floor. And ICU tends to have very critical patients who, more often than not, could be the ones that tend to get sepsis and get very ill and not recover as well. This is the section of the rapid response orders for the stat nurse on the sepsis protocol that they have available to them. As you can see, it does not include any antibiotics, and this is the only access to readily available orders for sepsis on inpatient floors. There are no standing orders. The doctor would have to be notified and suspect that it's sepsis, and then start individually ordering things. So some of the suggested changes that I have made involves allowing ICU to have access to the same standing orders on sepsis as ED has, allowing the stat nurse to have access to an order for a broad-spectrum antibiotic for sepsis of uncertain etiology. I want to take that specifically from the general order set that was set for ICU, so that there are already orders that the doctor would have put in for uncertain etiology. And that will allow the inpatient floors to have access to getting the immediate treatment they need for the patient who has sepsis or is suspected to have sepsis, while they're waiting for the doctor to be able to contact them back about further orders. There should be a policy in place with screening orders and protocols for all units of the hospital. My recommendation is that the nurses should be screening every 4 hours for patients with diagnoses of sepsis or sepsis rule-out, infection, or post-surgical, things that put the patient at a higher risk for developing sepsis. And every 8 hours for patients not fulfilling that criteria, because anybody can get sepsis, anything can lead to it. The hospital should be utilizing electronic screening tools that CareConnect offers, such as their Muse program that changes color besides the patient's name, warning them of signs or symptoms that could be leading towards sepsis based off of the information that has already been documented, such as the vitals and abnormal lab values. Or if these are not specific enough, perhaps the PeaceHealth should look into getting customized ones that notify the nurse or the doctor about these symptoms. And there should also be orders in place for inpatient units to notify the stat nurse for further assessment of a positive screening. So if the computer tells them that this patient is showing positive screenings for sepsis, they should be assessing their patient and looking for changes in their cognition and looking to see how the client looks and the manifestations that could be shown in that, and notifying the stat nurse who can initiate things and orders to treat this if the stat nurse feels that is necessary. And they can notify the doctor when they've already started the treatment or before they start it, and then waiting for the doctor to come back with their orders. So the patient has the best chance of getting their antibiotics and their fluid resuscitation within the recommended times. This is an example of the change that I want to do for the rapid response orders for the stat nurse. It's an easy fix with minimal effort because there are already orders from other protocols for sepsis. So this is the original sepsis portion of rapid response orders for the stat nurse on the top, with the additional orders from the general order set sepsis focused that specifies the uncertain etiology, so the broad spectrum antibiotic for sepsis that could be started immediately while we're trying to get results for a more specific one. Having that policy in place and a protocol for sepsis can save lives. It can prevent the sepsis becoming severe and having permanent organ dysfunction, and it can limit the average amount of days a patient needs to be in the hospital because we're treating it before it gets worsened. This is the research that I reviewed on sepsis and the protocols. You'll see at the very bottom that is the Surviving Sepsis campaign, which has an easy website to be looking at that has the bundles and guidelines readily available without any cost, that are evidence-based and backed by plenty of research-oriented organizations. I reviewed a lot of journals. Some were for nursing, some involved physicians as well involved. The Peace Health orders are also on there. There was an additional one that I did not discuss about, which was the Critical Care Nursing Acute Changes Protocol, which is also an order set for ICU. And also not standing orders. It has to be separately ordered. So if you have further interest in reading more about the literature that I have reviewed for you, these should be available for you. Thank you.